On this episode of the Ask Mike Reinold Show, we have another great baseball-related episode where we talk about some of your questions. We talk about the equation of acute to chronic workload and how we use that with weighted ball training. We talk about how we can differentiate between internal and external rotation loss with total rotational motion. And we talk about the importance of restoring full elbow flexion after Tommy John surgery.
The Ask Mike Reinold Show. Helping people feel better, move better, and perform better.
Welcome back, everybody, to the latest episode of the Ask Mike Reinold Show. I am up at Champion PT and Performance up in Boston. I'm here with Lenny Macrina.
It's great to be back.
Lenny comes
on vacation.
Returns from a sabbatical. So what do you do? Professors in school take sabbaticals, right?
I feel refreshed. I found some pants to wear, Dan, so you're welcome. I found pants instead of shorts, and I feel good. I'm ready to answer some questions.
Rejuvenated. It took a month off. He's pretty good. Dan Pope, how are we?
Good.
Is your fitness pain-free? .com?
A little bit, yeah. It is generally, yeah. So, yes.
Awesome. We are up here. We have a couple of our awesome students here joining us as usual. We got Mike, the Skidudo from Northeastern University. We have Keisha, what the heck, from Regis University? College. It's the same. What's the difference between university and college?
Want to have a grad program?
I don't know, maybe. Sure.
Crickets.
Yeah.
Somebody tweet us, let us know what that is.
Yeah.
Anyway, we are back here. We have an awesome baseball episode. We got some questions specific to some baseball type things that we know you guys are going to love. So let's take it away. Who's doing the questions?
I got the first question.
Awesome. Skid.
Jared from Long Island. Hey guys, I recently attended a workshop hosted by Dr. Tim Gavitt, and the most interesting concept that I took away from him was his acute-chronic workload ratio. Basically, if we ramp up too quickly, acutely, more than our body has been prepared for chronic, we increase our risk injury. Applying this to the weighted baseball training, how should we be monitoring volume from the acute standpoint? In other words, what's your way of slowly introducing weighted baseball throwing to someone who is physically mature enough?
That's awesome. So I like the way, Jared, right? Jared, yeah. Jared, I like the way you're even thinking, right? You're thinking about how do I apply weighted baseballs a little bit more scientifically or so. So the acute-chronic workload ratio is definitely an interesting concept that I think in sports science we're starting to utilize more and more, or pay attention to more all the time. And Dan, I'd love to hear your thoughts on fitness on this, but you know what that means to the readers essentially is like it's a comparison of how chronically what you've been doing for workload. So let's say throwing for the case for baseball, chronically, you know, what's your volume, your intensity, your duration, all those things, what's that been, and do you have any acute spikes? So if you have an acute spike where all of a sudden you've been playing catch at 60 feet, but you decide to long toss to 300 feet or throw a 2-pound ball, you have a large spike in your acute workload, so that changes your acute chronic ratio. And interesting enough, we just had a big meeting with Modus Global, the makers of the M-Throw, is that what it's called, the M-Throw thing? The chip sensor that you can put on your elbow that measures strain on your elbow during throwing. So and they're introducing this new variable as well, that acute chronic workload. So interesting.
I think it's a definite interesting concept. It really, when I heard it, I was like, interesting. And I just started following Tim Gavitt on Twitter too, and he's got some interesting stuff that he puts out, and I'm very impressed with his thinking process, thought process. I think it's just going to be coming up with equations to figure out what is acute, chronic, what does all this mean? Like, how do you determine your volume and put that into a common number versus your chronic load over a period of time, and figure out your peaks and valleys and when you need to shut it down because your acute load is too high. So I think it's a really interesting concept, and it was kind of mind-blowing for me when we sat down with Modus.
Mind-blowing. Lenny's mind was blown.
I love Tim Gavitt stuff, and then to draw like a corollary with baseball, I think I try to apply it to pretty much everything I do, from exercise or fitness to even like manual techniques, just dosing at a low level and starting to slowly build up. I think there's a lot of just very smart. I think we have to be careful though, because if you think about the athletes that they're doing the studies on are mostly rugby and I guess soccer or football, I guess, in other countries.
Football.
I think for throwers, if you shut them down for like 4 or 5 months out of the year, the risk of injury goes down quite a bit. So I'm curious if it's because I think what Tim showed initially was that if you just did too much in general, volume-wise, it's going to predispose you for injury. But then the next thing they found was that these high training loads are actually protective, but for a thrower, we might just not want to throw as much, potentially. I mean, just because a football player is not the same as a baseball player.
Right.
So I love that concept, but I'm just really curious to see what happens from a pitching perspective.
I think you said it best. The problem is we know that if kids shut it down for 3 or 4 months out of the year, they lower their risk of injury, but kids aren't shutting themselves down for 3 or 4 months out of the year. And so they're a chronic load, keeps rising.
Yeah, that's not just a high chronic load, which is fine. But
right.
I mean, getting back to the acute chronic ratio in your question, you brought it up with weighted ball training, right? And if you think about with weighted ball training, that's the easiest thing in the world for you. They're training with you. You're in charge of their acute chronic ratio. The challenge with that is during the season when you can't control their workload, then you have to monitor that and play that. That's if you have a large spike in innings or innings pitched or whatever it may be. You're a reliever, you go 3 out of 5, 2 out of 3, something like that. Like that's the type of thing that it's hard to manage. For you, it's super simple to manage this in an off-season program. You just build a program that gradually increases intensity, duration, frequency, loading, volume. I mean, all these things. You just be gradual with that. So when you build your program and you periodize kind of this weighted ball implementation, then you have to think of that. And that's an intelligent way to do it, right? Now, so you can monitor this, right, by just simply taking good care to track your programs. Don't let the kids do whatever they want to do. You prescribe them a certain kind of a program so that way you manipulate those variables and increase them over time. And that's how you do it. It's more in season that I think is the challenge.
Good.
We're all sick here at Champions. We're all recovering.
Probably gonna edit that out, but that.
Matt from Los Angeles says, "Hey guys, love the podcast. Question about total rotational range of motion of the shoulder joint. Say a patient has good overhead mobility, but total range of motion is lacking on the affected side. How do you decide which direction, internal versus external rotation, to try to improve?"
All right, so total rotational range of motion, that's ER plus IR measured at 90 degrees. So if somebody's limited and their total rotation is less than the other side, how do you determine if it's ER or IR? What do you do, Len?
Well, I measure both, and I want to see, I want to look at end feel. I want to see what their end feel is into external rotation. Do I have any pain at end range external rotation? And I compare internal rotation, external rotation, compare external right versus external left. And I probably like to see at least a 10, 15 degree difference in their external rotation, which is kind of going to correlate with their retroversion. And so we know that side gets more retroversion by throwing with their younger age, so we expect that change to be, say, 10 to 15 degrees. And conversely, we expect their loss of internal rotation to correspond with that number too. So I like to see at least 10, 15 degree of external rotation difference. I don't know if you look at anything.
My take home from what Lenny just said there was that you have to have an understanding of what thrower shoulders typically look like, which Lenny does. So he gets that. So I think when Lenny's going to look at someone, he's going to be able to tell right away what the limitation is because he knows what to expect. What I would say is there's going to probably be one, either ER or IR, that is different or similar side to side, right? So if you're worried about which one it is, let's say external rotation, you're 120, 125, 120 on the non-dominant and 125 on the dominant, and then internal rotation, there's a 20 degree difference, then okay, if there's a 20 degree difference, then it probably should be 20 otherwise, right? So I don't have a strict number like Lenny, but I think that's a good general rule of thumb, and that's a good way to start, is to know what to look at. But I think you just add up the difference side to side and see where maybe the disagreement is.
Big discrepancy.
The discrepancy, that was the word I was looking for. Disagreement. I don't know if your range of motion disagrees with itself. So.
Hope that makes sense.
Yeah, good, right? Good, solid? All right, let's nail it. What's number 3, Skid?
Okay, Daryl from Georgia. How important is full elbow flexion following Tommy John surgery? I have a collegiate pitcher who is 8 months status post Tommy John and is doing well with everything else, but continues to have difficulty with end range elbow flexion. greater than 125 degrees. This does not affect his throwing. He has no pain with his throwing program. He has full elbow extension.
Okay, so how important is restoring full flexion after surgery? Len, how common is it to lose some flexion? Let's start with that.
As common, but definitely not as common. If you're gonna lose something, you're gonna lose extension. I'm curious as to why he's losing flexion.
Right.
The only thing that bothers me is if he's lost flexion, it's not coming back. Like, what's going on? What's the underlying tissue? Is there an inflammation thing? Is there a capsular thing? Like, why is this going to be something that's going to creep up down the road that their elbow was cranky during the rehab process and now they go to throw for 3, 4, 5 innings and have to throw 70, 80 pitches? What's the implication on the elbow if they couldn't even get basic flexion back? So I'd be a little worried. Yeah, it's not going to affect their mechanics, we don't think. They're not going to necessarily need 130 degrees of flexion, and they're functional probably. So I just think the underlying tissue quality, there's something going on that would worry me.
Yeah, that's a good point. I hadn't thought of that when I first heard the question. Is maybe that's indicative that something else is going on that you should be paying attention to. So definitely take a peek at that. I would also say too, sometimes guys they don't have it before surgery.
Correct. Yeah. What was their baseline?
We always say the elbow is a really congruent joint that scars really easy. So you can have some bony abnormalities from the act of throwing that has odd limitations of your elbow. I've seen guys with 90 degrees of flexion, that's it, and they can't get past here. It happens, and you can see some ossifications in the anterior capsule, things like that. If you're concerned about it, I think Lenny brought up a good point. If it's not doing well, if it's not feeling good, or throwing's not going well, which doesn't sound like it's the case for you, but if that is the case, then you would think, okay, what's up with the tissue? But I wonder if it's just some chronic changes with him.
Yeah.
You might be able to see like the pre-op X-ray or MRI, and they might even have some kind of interesting findings in there that you might kind of figure out why and say, oh, intraoperatively they only had 125. I'm not going to get more than that. So something to think about, right?
Yeah.
Yeah, but not a super worrisome kind of thing.
Just something to keep an eye on.
Yeah, extension's worse, but even if you lose a little bit of extension, it's not the end of the world, usually. But again, shows you something though about the irritability of the elbow. So awesome. Good. Nice. Awesome. Well, I love it. Thanks so much, guys. Another great baseball episode. We're going to continue to do some of these baseball ones because we got a ton of great baseball questions. So keep asking away. Go to AskMikeReinold.com. Click on that link to the podcast. No, that's not the website. It's just MikeReinold.com.
That's where I go.
I'm not good at this. So thanks, Dan. But go to MikeReinold.com and click on the podcast. Ask us some questions, and more importantly, if you don't mind, follow us, rate us, review us on iTunes, and we'll see you guys on the next episode.